Hi, my name is Yuri Paschuk. I'm a nurse manager and also an MSN grad student at Liberty University. And I want to talk to you today about eliminating CAUTIs and focusing specifically on catheter utilization reduction. Let's talk a little bit about what the problem is. The progressive care unit has seen an increase in their observed or expected ratio of Foley catheter utilization, meaning the frequency and the number of catheters used on their patients is higher than what is recommended. It's higher than like model units nationally, and Foley catheter utilization has been shown to increase CAUTIs, or catheter-associated urinary tract infections. What this does is it often carries a financial burden to the organization of upwards of $30,000 per CAUTI case that drives the cost of healthcare. Let's talk a little bit about what the current state on the PCU is. So the rate of catheter utilization is about 45% on the progressive care unit. Several of the in-process measures to help reduce not only CAUTIs but decrease catheter utilization are focused around insertion techniques, being conscious and aware of how a catheter is inserted, following sterile technique, following proper procedure and guidelines, maintenance techniques focusing on the patency and assessing catheters daily to make sure that there are no obstructions, there's no mechanical issues, and focusing on keeping the bag, the catheter urine collection bag, below the patient's bladder for allowing for optimal drainage and not a return of urine back into the bladder. One of the hospital initiatives to decrease erroneous culture results has been to send off a urinalysis first, placing a urine culture on hold until a urinalysis came back positive for an infectious process, after which the urine culture would be sent off. This has been shown to decrease false positive urine cultures from contaminants such as biofilm. And finally, an emphasis on leg straps or leg immobilization devices that help keep the catheter tubing in place when moving patients, transferring them, or ambulating them to help decrease potential trauma or pulling on the catheter that can be associated with an increase in infection rates. What does evidence-based practice tell us? When it comes to reducing CAUTIs, or catheter-associated urinary tract infections, there are several organizations that dictate what we should be looking for and how we get there. The National Healthcare Safety Network, or NHSN, recommends that PCUs, or progressive care units, should see a rate of catheter utilization closer to 20%, meaning patients on a progressive care unit should be utilizing catheters or catheter utilization closer to 20% of their total patient population. The Joint Commission also recommends in their R3 document that the only way to truly prevent or reduce CAUTIs in the hospital setting is to decrease the catheter utilization, meaning if you can decrease the number of catheters you use, you're more likely to decrease the number of CAUTIs associated with catheters in a hospital. So let's talk about some of the different innovations and changes we're starting to see in healthcare that are moving the needle and changing our culture. Things like task forces or physician engagement with physician champions, and also nurses taking autonomous roles in order to create a culture of change. One of the more popular innovations that we're starting to see surface are CAUTI task forces, or specific teams designed to focus on CAUTI reduction. These are often multidisciplinary teams that include players such as pharmacy, nursing, physicians, nursing leadership, performance improvement, infection control, And the focus of these groups is often to not only look at evidence-based practice and what evidence is showing us, but also use data to drive change by establishing a baseline and then working towards what evidence is showing us and what the recommended standards are. Part of the collaborative process is also focusing on opportunities to designate physician champions. This is something new yet innovative in the sense that physician champions have been shown to not only collaborate with staff such as nurses and pharmacists, but drive change on specific units. Identifying local champions or unit-based champions can help drive that change because it allows a physician to be familiar with the guidelines and recommendations and continue to not only support but collaborate with staff to ensure that everyone's on the same page when it comes to providing that level of care for the patients. And finally, while not a new and innovative concept, but empowering nurses through nurse-driven protocols has been shown to decrease Foley catheter utilization rates and drive the CAUTI rates down by allowing nurses to decide to remove catheters without a physician's order. Protocols such as a bladder scanning protocol give nurses the ability to visualize and determine if there's urinary retention in a bladder before inserting the catheter. Assigning nursing champions is also innovative as it allows certain nurses that are passionate about a change process to become the experts on the specific unit or specific service line and encourage their peers by being a resource to them. An evidence-based practice with data and metrics. So as nurses continue to grow and develop with education, it's important to provide those tools for them to not only drive change through the evidence-based research, but also demonstrate it with data and graphs depicting baseline and data trends and where this change is heading. So why isn't the current process working? Well, when talking to several staff through surveys and open dialogue, we've discovered that catheters are not always being discontinued and discontinuation orders are not always followed. Some staff have commented that physicians are still reluctant to discontinue catheters. There's also myths about skin breakdown, and when removing catheters can lead to urinary incontinence and skin breakdown. There's myths about inaccurate intake and output. Staff are concerned that when catheters are removed, they will not be able to adequately track their output. And then the idea that everyone on diuretic therapy such as Lasix or furosemide needs a catheter in order to prevent skin breakdown and ensure accurate intake and output. So how can we as nurse leaders begin to move towards change? Specifically with CAUTI reduction and catheter utilization reduction. Rapid process improvement events have been successful in creating change by identifying specific barriers or areas of opportunity where staff may feel that change needs to occur in order for success to occur. Incorporating data into communication and conversation with staff can demonstrate not only trends but where we need to go, giving them visual aid in the process. Team approaches are key as it allows for staff to become engaged. So using unit practice councils or task force teams in order to collaborate, allowing staff to participate in unit-specific decisions and change projects. And then reporting on the progress. It's important to not only demonstrate what the process is, but also report throughout the change process, giving staff accurate and timely feedback on some of the change metrics, some of the areas of opportunity and growth, as well as the progress made within the unit. Like any change projects, there's often risks associated with change. Staff may be afraid of change or afraid of yet another change in a process. There may be fear of failure. We've tried this before and it didn't work, so why are we trying this again? There may be disbelief or lack of understanding around why this particular time we should expect this to work. Reluctance to change can often be associated to a unit-specific culture or a generational gap. We've always done it this way, so why are we changing it now? Is it really a problem, or is it really my problem? And then an increase in workload. There might be a risk of fear associated with removing catheters will increase the number of work I have to do. We already work short or undermanned, and so now we're just creating more work for the staff. As nursing leaders, it's often important not just to recognize risk, but work towards reducing risk. One of the ways we can reduce risk with change projects is reinforce good behavior, positive behavior among staff, finding those nurse champions and supporting them in their efforts to drive change. Other ways we can reduce risk is by providing proactive education on evidence-based practice, hands-on training with equipment and tools that can help reduce catheter utilization, and allowing them access to supplies such as female urinals and condom catheters, along with skin protection barriers, so that staff can feel that they have the tools they need to help support the change project. Rounding is another key factor of nursing leadership, being present and available to staff to not only answer questions but help see the good behavior, reinforce the good behavior, and recognize it. Engaging staff with unit practice councils, morning huddles, shift change, and being available to listen in order to hear what their concerns are, where the problems lie, and how they can help solve some of the problems and reduce some of the risk associated with change. As nurse leaders, it's important for us to recognize that when implementing quality change processes, errors may still occur. When an error occurs, utilizing just culture can help determine the root cause of the error by identifying whether it was a process error, whether it was a system error, or whether it was a human error. Positive reinforcement with good behavior can help staff feel comfortable and confident coming forward with an error, ensuring that patient safety always comes first. And providing ongoing education is key, not only in the initial phases, but throughout the process and when errors occur, to help reinforce positive behavior, reinforce process changes, and help continue build a culture of safety, not a culture of fear. Finally, once implementing a quality change project, it's important to monitor its progress throughout the change. Looking at metrics and current guidelines is important to help ensure that the process is being followed. Data and reports are valid in not only establishing current state, but demonstrating the change, the progression of change, and providing visual aid to staff to ensure that they are involved in the process change. Staff self-reporting has been shown to reinforce the autonomy and drive the change. One of the units that has implemented other changes was able to engage staff by allowing them to document when they utilize nurse-driven protocols and reward the highest users with incentives, encouraging others to participate and increase their nurse-driven protocol utilization rates. Some of the ethical considerations are important as well. So reporting errors are a key component of ensuring that staff feel confident and comfortable enough to come forward when an error is occurred and report it without fear of ramification. One of the other ethical considerations is incompetence, or ensuring that staff don't lack the education or ability to follow through on a change process, ensuring that they have the tools to safely care for the patients. And then honesty. While this may be a sensitive subject, honesty does play a big factor in ethical consideration, focusing on staff being transparent in not only implementing the quality change project, but honest enough to come forward when the process isn't working, allowing for transparency in gaps or barriers.